to explain and to introduce myself in a new role that has now started and that I'm now doing in the NCC. It's quite an exciting role, and it's a whole new role that that has never been in Ireland before in haemophilia care. So it's important for everybody to understand what the role is about and also how they can avail of it if required. So I really appreciate this opportunity. So the first part, I suppose, is to explain what an ANP or an Advanced Nurse Practitioner is. So they are essentially it's essentially advanced nursing and midwifery practice that is carried out autonomously by experienced practitioners who are deemed competent, accountable and responsible for their own practice. So advanced nursing practice is grounded in nursing theory and practice of nursing, and incorporates nursing and other related research, management, leadership theories and skills in order to encourage and collate a multidisciplinary approach to quality of care. So essentially what that is, in a very long fancy words, is stating that even though they are independent practitioners and they can sometimes, the role can be quite similar to a medical practitioner, but they still are very much ingrained and incorporating nursing and the theories underlying nursing. So there is still a difference between a medical practitioner and a nurse, a nursing advanced practitioner. So, and essentially what they can do is they can interpret the results of multiple different assessments, investigations, and they can diagnose and plan delivery of care. So in comparison to a clinical nurse specialist is able to deliver care. They can also make clinical decisions, but the difference is that an advanced nurse practitioner is more autonomous in the way they do it. And they don't necessarily need to have a medical practitioner to specifically state what that plan and delivery of plan of care is. Though the governance remains with the medical practitioner or the doctor or consultant within the unit. So the ANP can prescribe and work with individuals to manage their medications. So essentially what my new role will involve is that I'm actually able to, which I previously was able to prescribe, but I'm able to actually make the clinical decision as well surrounding medications and also how and assist patients in managing those medications as well. They work independently, but they also must work as part of as an interdisciplinary team and multidisciplinary team. So they, even though they are independent, autonomous practitioners, they do work within a team. They're not a standalone unit. So in summary, I suppose, trying to describe what an ANP is that they manage caseloads independently, but within their scope of practice. They diagnose, they assess, and they treat patients. They prescribe medications and investigations. So I can also prescribe radiation as well in relation to X-rays, MRIs, CTs. They can refer to other disciplines, and they also complete full clinical episodes, which means, I suppose, they can admit patients and also discharge patients. So when they come under their care, they can keep them under their care and but also discharge them from their care as well. So I guess, where does the idea of an ANP and haemophilia come from? The UK HCDO audit in 2011 and in 2018 actually suggested that one of the downfalls within nursing and within the NCC was that the nursing team were not working at an advanced level, and that there was not an advanced nurse practitioner on the team. It also has been suggested by the National Haemophilia Council, but also by the HSE. So there's a big drive at the moment with Sláinte Care surrounding chronic disease management. So the HSE have suggested that all chronic disease areas should have an advanced nurse practitioner to manage chronic disease. So the history of the NCC ANP, I suppose the ANP, the first ANP in Ireland was developed in the emergency department in 2002. And that was actually, the first person was actually in St. James's Hospital, the ED department. So the NCC first proposed a role in 2012 following the UK HCG audit. And it was a multidisciplinary team approach, but unfortunately it was unsuccessful for funding at that time. In 2016, we restarted the process to develop the role again. And thankfully, in November 2019, the ANP in haemophilia was achieved. So I guess comparing internationally in other haemophilia centres around the world, just personally, I know that there are ANPs in the majority of the centres, and the ones that I know personally would be the Netherlands, the United Kingdom being Debbie Pollard, Kate Kerr, Kathy Harrison over there in the UK. The USA have them, Canada have them, Australia have them, Switzerland have them, and I've no doubt there's many other countries that have them too. So it's about time Ireland had one too. They're available in many specialities in Ireland, and predominantly there's a lot in ED, there's a lot in many chronic disease areas such as respiratory, diabetes, rheumatology, and they're the ones that the HSE have been aiming at specifically over the last couple of years. And the aim was to reduce down waiting lists, to improve continuity, and also to improve patient flow. So it's not a straightforward process, and that's why it's been such an achievement for us to get one. Candidates as an advanced nurse practitioner must be educated up to a master's level, which wouldn't be standard in nursing at all. They also have to have a postgraduate certificate in advanced practice, and they also need to be a registered nurse prescriber. So it isn't, to achieve these three things does take a significant length of time. They're three individual different courses. So by the time the nurse actually achieves all three, they're quite experienced in that area. So what's the aim of the ANP in haemophilia? And so basically, the aim is to complement an existing high quality haemophilia service. It's to develop and expand existing haemophilia services. It's to implement, innovate autonomous nursing practice for patients with severe haemophilia, and also to improve patient outcomes, which would be the aim of all of the above. So how are we going to, in the NCC, achieve this? The first thing is ANP-led clinics. So at the moment, I'm running clinics on Wednesday mornings that are nurse-led. There's also ANP rapid access clinics. There's also coordination and evaluation of switches to product switches, and also there has to be a drive in nursing-led research. So I'll go into details with those four later on. So what can an ANP do? They can do clinical reviews, which is both routine and acute care. As I said, I can prescribe medications and investigations, and refer to different disciplines, and I can also coordinate care to improve the efficiency of it. So nurse-like clinics, they're the first ones, and they were the first things that got up and running. I only got in the role in February, which was just before, obviously, the COVID-19 lockdown, so things changed very rapidly for me. So the aim of these nurse-like clinics are to optimize treatment regimens. So it's to sit down and discuss with the individual to deliver a personalized treatment plan. And it's to optimize that regimen that they already are on, but it's to ensure that this remains correct and it's doing what it should do. I also manage switches to different treatments. I aim to improve continuity of care. So certainly some feedback from patients over the years is that each time they come in, they have to repeat their medical history to somebody different, and also to explain what haemophilia is. So the aim of these clinics is that you don't have to do that anymore, that you're able to sit down with somebody you already know and who knows you very well as well. The aim also is to promote self-management, and also you're able to self-refer as well. easier access to clinics. So I'll go into more detail about what's that in the future. And also, as I said, personalised care. And the aim is actually to increase patient autonomy and also patient empowerment. So the aim, obviously, with promoting self-management and self-referral is that patients, when they feel they're getting into difficulty, are able to actually contact me and book in directly to me. There's flexibility surrounding that. The aim at the moment is that I'm doing clinics on Wednesday mornings, but the aim long-term is that they are going to be a lot more flexible. So, for example, I'm going to be able to, if you're coming in for a procedure, I should be able to do a clinical review at the same time to save you coming back on a different day as well. So again, I would take the patient autonomy as well to be able to let me know that these things are happening, you know, so that I can try and coordinate that care for you. So the nurse-led rapid access clinics, I suppose, is a little bit of a fancy name of what already occurs, but I guess the difference is that you're accessing an ANP rather than a whole team. So the rapid access clinics can be for advice, but in addition, it can also be an assessment of a bleeding episode or a query surrounding a treatment regimen as well. So it can be anything of the above. The aim of this is to improve access to assistance and also advice when it is required, rather than having to wait until the next time you come to clinic. At the moment, obviously, due to COVID, it sort of pushed it a little bit further for us, and the clinics were set up slightly different than what they were originally proposed. But these rapid access clinics can be done in two different ways. The first one would be teleclinics, so I can assess over the telephone, or I can actually do a video call as well, where I can actually link directly to you, so you can actually show me the area that's of concern if there's a bleed or anything. But also face-to-face contact, which is very, very important. So sometimes a teleclinic could actually turn into a face-to-face, whereby actually I would need to call you in directly for an assessment, because it's not possible and it's not appropriate to be done over telehealth. But certainly some clinical episodes and some bleeding episodes can be done through telehealth, which hopefully will be the majority of them. Very important to highlight the fact, as I said previously, that actually ANPs do not work alone. They have to work as part of a multidisciplinary team. They're not successful if they just sit there on their own at all. So part of that is I work as part of as an overall nursing team and complement that team. So it's very important that I am part of that team and remain that way. Also consultants and SPRs. So the overall clinical governance remains with the consultants. So we will be having daily discussions surrounding what occurred during the day and what type of caseload came in through the day, and patients who had rang and queries. So that support is always there for the advanced nurse practitioner and will remain so. The allied healthcare professionals, obviously, the physios, social workers, and psychologists on our team. So pretty much most days I will be contacting one or more of the allied healthcare professionals on our team to discuss patients. So again, that's very important. And also assistance by administration. So I certainly couldn't do my job unless I had a good team of administrators behind me as well. So as I previously said, what are the benefits, I suppose, of being under the care of the advanced nurse practitioner? And the main thing, I suppose, would be improved continuity of care, as I said previously. Improved access to expert care in a more prompt and streamlined way through teleclinics and rapid access clinics. And also easier and more flexible access to healthcare and support, which I think is vitally important for anybody who's got a chronic condition of any description. So I guess where to next? The role is evolving. It's very new. As I say, I only started in February, and obviously there was the COVID-19 lockdown that occurred for the coming weeks after that. So it is very much evolving and will continue to do so. It won't stay stagnant. So the role will continue to support patients and staff during switches of new treatments. So obviously the most recent one being emicizumab or Haemophilia. But as we all know, there are many other developments in products and treatments that will be coming online over the next coming years. So that's what my role will be, to support people through those switches to those new treatments that come on the market. More focus on nursing research. It's not been one of our strong points over the last couple of years. Certainly we and the nursing team have been involved in research, but we haven't specifically led our own particular research projects. So that will be certainly from the last quarter of 2020, my aim will be to have a substantial research project under my, certainly started and proposed by the end of 2020. The aim would be towards more qualitative data, using focus groups or questionnaires to be able to achieve that. But that's very much at the idea stage rather than anything else at the moment. There'll also be further developments on the telehealth. Certainly, as I said, I've been doing a majority of my consultations by telephone. I have done a good number of ones over video consultation as well. The video consultation, I must admit, is my preference. And the reason for that is because there's an awful lot to be said to be able to make eye contact with the person that you're having a discussion with. Even though a lot of people don't like people seeing them in their own home, you know, or seeing themselves on a screen. I think that the information that you get from each other is really, really important. And there's subtle signs that we don't really even notice we're doing. But I do think that the video health is certainly a preference for myself, and anybody who I have done them have enjoyed them too. So I certainly will be trying to promote them more. But I will also be involved as well in the patient portal. So hopefully the telehealth and telemedicine obviously will be part of the patient portal in the future. So that will be a major role for me too. In addition to what I do, I suppose day to day, it's quite important that I monitor patient outcomes. So I will have aims within my roles to see how the impact of the advanced nurse practitioner has on the care I'm providing. So it will be important for me to do that. They have started, but certainly haven't been overly evaluated yet because it's at a very, very early stage. But once we have that up and running and I have more results, the aim will be that I'll be able to initiate changes based on the evidence that I have found through the changes that have occurred with the advanced nurse practitioner clinics, being the nurse-led clinic, but also the rapid access clinic as well. So I guess very importantly, how does anybody access the service? And who can access the service? So my general, the patient population that I look after are severe haemophiliacs who are on home treatment, and there's a specific group. There's multiple ways that you can actually access. You can choose to see the advanced nurse practitioner, or you can choose not to. There's no push either way. Whatever suits the individual is perfectly fine. There are some situations that there will be, as I said previously in early slides, there is a scope of practice that is involved. And sometimes some cases are not ideal for an advanced nurse practitioner and are more appropriately led by a consultant. But we will very clearly explain that to you if that's the case. So you can access obviously through the normal NCC through reception. I do carry a mobile phone, and the mobile phone there is on the screen. That mobile is on while I'm on duty. You can text, you can ring. It doesn't make a difference which way you do it. It's certainly, if it's urgent, I would advise, if I don't answer the phone initially, to go directly to reception to make sure you get my attention. Because obviously, if I'm in clinics or I'm on a consultation, it can be difficult to answer the phone. If it's routine and you just want to call back, you can text and I'll call you back. It's not a problem. But if there's no answer to that phone, it means I'm not there, essentially. All right. So if the telephone is turned off, I'm not there. So you would have to contact the NCC directly. But additionally, I also, obviously you can access information or advice by email as well, if it's just routine. So you're not too sure if you have, I don't know, an appointment or whether you should be attending something relating to your haemophilia, then you can email, and that's not a problem. Again, if I'm out of the office, you'll get a reply to say I'm not there. But if I am there, I certainly will reply and help in whatever way I can do. So, so email is certainly appropriate as well. So there's 3 ways that you're able to access the services, or myself. So I'm hoping that between the combination of the 3, that there should be no delays or no issues surrounding accessing the services that are available. But certainly if there is, I appreciate any feedback. So that's everything, guys. I hope I was clear enough about what the role is. I really appreciate some questions because I think a discussion and feedback is really, really important because it's so new. So if anybody has any questions or anything like that, please, or feedback, please say it now. I'd appreciate it.
Thanks very much, Niamh. Can I start? Can you hear me?
Absolutely, I can. Thank you, Brian.
Okay. Can I start off? So you've set out the differences between an advanced nurse practitioner and a doctor. So you've set out what the ANP can do. Can you give us a quick boilerplate summary of what's the difference between ANP and a doctor now in the service?
And a doctor?
Yeah.
So, so the ANP would be quite focused. So I